our first speaker, Dr. Peter Savino. My friend and mentor, Dr. Savino, is a clinical professor of ophthalmology, neuro-ophthalmology in the University of California at San Diego. For over 30 years, he was the director of the neuro-ophthalmology service at Wills Eye Hospital and a professor of ophthalmology, neurology, and neurosurgery at Thomas Jefferson University. Dr. Savino, in my opinion, wrote one of the best practical books in neuro-ophthalmology. I read his book as a resident, and then I did a fellowship with him. Clinical Decisions in Neuro-Ophthalmology. He's a prolific scholar with over 200 articles, 40 book chapters, and a reviewer for 14 scientific journals. Amongst his most significant achievement, I would say, is that he makes people, average guys like me, get some handle on neuro-ophthalmology. So Dr. Savino is going to talk to us about demyelinating optic neuritis.
I'm just going to talk a little bit about optic neuritis. My approach to neuro-ophthalmology is I'm a simple man, and I just sort of talk about simple things. So you won't hear any radical comments from me or radical concepts. So let's talk a little bit about optic neuritis. Now, optic neuritis, just the term optic neuritis, means any inflammation in the optic nerve. All right, and of course this can be due to any number of causes, and I think Dr. Chavez probably will address those later. But any inflammation, any infection can cause an inflammation as well, and that can legitimately be called optic neuritis. However, I think it's fair to say that in the United States and probably in most of the world where the disease is prevalent, when we talk to each other about optic neuritis, we're talking about demyelination. We're talking about the optic neuritis that accompanies multiple sclerosis. So that's what I'm going to talk about largely today. And I'm going to talk a little bit about how I approach a patient who has optic neuritis. And I think that Andy Lee will have a little bit of a difference on this. I know because we talked about this on a very long train ride through India. So we have a little bit of a different take on it. But this we agree upon. You usually have decreased acuity, but you do not have to have a decrease in visual acuity to make the diagnosis of optic neuritis. You can have optic neuritis with 20/20 vision or 20/15 vision. So the decreased acuity is not necessary. However, you have to have some sign of an optic neuropathy. And in the optic neuritis treatment trial, the one thing that you had to have in order to be admitted to that multiple sclerosis or the optic neuritis treatment trial was the presence of an alpha-ampullary defect. If you did not have an alpha-ampullary defect, you were not admitted to the trial. So I would say that this is probably the most important sign to look for. And since I moved from Wills to Southern California, I'm sort of learning a whole new group of doctors, and I'm reminded of how often in general ophthalmologist's office and retina doctor's offices that the technicians check the pupil, and no alpha-ampullary defect is written almost routinely. So checking the pupil is one of the things that I do on every patient myself. I never let the resident or the fellow dilate a pupil until I check it myself. Pain on eye movement is an important sign. If you cannot elicit pain, particularly on eye movement, at the beginning of this episode or preceding it, question the diagnosis. Not everybody has it, but about 90% of people will have it. And it doesn't mean that if you do have it, it's necessarily optic neuritis due to MS. But if you do not have pain, think of something else causing the problem. I like to check color vision, and I don't really care what you use to check color vision, whether you use the HLR plates, the Ishihara plates, red comparison, but in optic neuritis, decrease in color or desaturation is almost always present. And of course, visual field defects are present as well, and we'll talk about those a little bit later in the cases we're going to present. And the optic nerve, when you look at it in acute optic neuritis, is either normal or swollen. And it's normal 2/3 of the time. So 2/3 of optic neuritis is retrobulbar optic neuritis, whereas 1/3 is papillitis. Now, when a patient comes in to see me, they've already been on the internet, and there was a wonderful study that showed that I think 50% of the medical information on the internet is incorrect. So they come in with all of these things, at least half of which are incorrect. But the two things they really want to know is, do I have MS and will I get my vision back? That's what people want to know. So what can we tell them? First of all, everybody has heard if they have optic neuritis or read that they may have MS, and they are frightened to death of this. Typical optic neuritis, which is what we talked about with those symptoms, usually occurs below the age of 45, has pain in eye movement. We talked about the normal disc. And if you have a patient who has a swollen optic disc and the swelling is marked and there are a lot of hemorrhages, that's a patient who is not going to develop multiple sclerosis. So it's important to look at the fundus. If you have someone who has, you think, optic neuritis, but they've had it for 3 or 4 weeks and it continues to get worse, that's not optic neuritis. I'll give the patient 7 days of worsening at the most, and then I look for another diagnosis. The type of visual field defect, when I was a fellow, we were taught that it was a central scotoma, and if you saw an altitudinal visual field defect, it was a vasculitis from some other cause. That's not wrong. That's wrong. We have learned from the optic neuritis treatment trial that the most frequent visual field defect is an inferior altitudinal defect with some sort of central depression, and most of the patients, 90% or more, will get better on their own without medication. So, what do I do? If the signs of a typical optic neuritis are present, all of those things, a young patient, pain on eye movement, normal fundus, afferent pupillary defect, I do an MRI scan with gadolinium. I do not do any other blood tests. And it's interesting that most neuro-ophthalmologists will say the same thing. Yet when I see patients that they've seen, they've done Lyme titers, looking for lupus, and they do all sorts of blood tests. I never do any blood tests at all in a patient who has typical, and that's the key, typical optic neuritis. And when I do the MRI scan, this is what I'm looking for. I'm looking for these periventricular white matter lesions that you see in patients who have MS. And the reason that I look for these is that in order to answer the patient's question of do I have MS or will I develop MS, this is the most important prognostic factor. This and only this is the most important factor to determine whether they will develop optic neuritis. So if the MR is positive, this is where Andy and I disagree a bit. I send the patient off to a neurologist to consider immunomodulation therapy. Are there any neurologists here? Besides you guys. All right. Do you treat people with immunomodulation therapy? It's interesting, I'll send patients to the neurologist, the MS neurologist, and they'll start someone drug and they'll start others, and I have not been able to find a pattern that they have. Now, I know Andy we were on this train ride through India, Andy, Neil Miller, and myself, and we said if we had optic neuritis and an MRI scan that looked like this, would we take medicine? And Andy and Neil said no, and I said yes. So, unanimity of opinion in the neuro-ophthalmology community. And this is what the optic neuritis treatment trial showed, that when you have MR lesions, and this is just the statistical display of what I said before, that the presence of lesions on an MRI scan is the single best indicator of whether a patient will develop clinically definite multiple sclerosis in the future. And as you can see, over a period of about 15 years, it's up over 70%. And people who have no lesions initially, it's not zero. It's about 25%. So the overall risk of developing MS at 15 years is 50%, but I think that's a useless statistic. The real statistic are the bottom two lines. With no baseline MRI lesions, your chances that your patient will develop MS over 15 years is 25%. And if they have one or more lesions, it's 72%. And that's what you can tell them. And the reason that I start people or send people to start on medication is that there's reasonably good evidence that by putting them on immunomodulation therapy, you let the attack. And we now know that when you have an attack of demyelination, it's not like what I learned when I was a fellow, that it affects just the myelin sheath and the axons are spared. That's not true. Every time you have an attack, you lose more axons. And as we get older, we lose more axons, so we need to keep as many axons as we can. So, what do I do if the MRI scan is negative? I tell the patient that their risk of developing MS is low, but it's not zero. And what I do is I tell them if they have no further signs or symptoms, I will see them back in about 6 to 12 months, and I repeat the MRI scan at that time. If it's negative, the MRI is negative, and I have any suspicion that the optic neuritis is not typical, if they don't have pain on eye movement, if they have a lot of hemorrhages with a swollen optic disc, then and only then do I do investigations for other abnormalities. And I suspect that the other neuro-ophthalmologists here might have a different way of approaching this. Now, what's the role of steroids in typical optic neuritis? What the optic neuritis treatment trial showed, and I think that this is probably the most misunderstood aspect of the management of optic neuritis, is that people get treated with steroids for optic neuritis for visual reasons. And what the optic neuritis treatment trial showed is that giving a patient steroids does not improve the eventual resolution, does not improve the eventual outcome. If the patient is going to get better, they are going to get better without steroids. The only thing that the steroids do is they shorten the course of the optic neuritis. So if a patient is going to get better in 4 weeks, with the steroids, they may get better in 2 to 3 weeks. So the only time I ever use steroids in a patient to get them better quicker is if it's a one-eyed patient. Then I think it's important. Otherwise, I do not use steroids unless the patient is going to start on immunomodulation therapy, and then I give them a course of steroids before that. So that there is no reason to treat the visual loss of optic neuritis with steroids because you think you're going to have an effect on the recovery of vision. So in summary, what about optic neuritis? It usually implies demyelinating disease or MS. The long-term visual prognosis is very good. Over 90% of the people get better on their own. And, excuse me, and the people who develop MS also have abnormalities on our test for visual function, but even those who develop MS, vision is normal 60% of the time. So when you start off with optic neuritis, at least from a visual standpoint, this seems to be a relatively benign condition. I don't treat patients with IV steroids for visual reasons. It doesn't have any effect, and it does not alter the long-term course, except it shortens the recovery period by a week or two. That's all I wanted to say about optic neuritis. Any questions? Or well, you want to do questions after? Now what? Or after Andy and Pam? What's that? Oh, okay. All right. Any questions or comments?
Recurrent optic neuritis in a patient. Could be on interferon. He will give.
No, I don't. Or if someone has recurrent optic neuritis, I don't treat them with steroids because the study has not been done as far as I know. But there's no indication that if it doesn't work in the initial one, I'm not sure it works in the second one. Do you guys have any? Do you use steroids for recurrent optic neuritis? No, they don't use it because it has no effect on vision.
Actually, in recurrent optic neuritis, we have to investigate because sometimes there is an underlying cause of having recurrence, especially sometimes it's autoimmune disease.
The MRI scan looks like the one I showed you.
No, I mean normal, no, with normal MRI.
You have a normal MRI scan, and you have a recurrent optic neuritis. That's atypical.
Yeah.
To do what? Oh, that's a good question. The question is, if you have a classic history, why do you have to do an MRI scan? Just start the patient on steroids. And I think you can start them on steroids, but I wouldn't subject them to the immunomodulation therapy unless they had an abnormal MRI scan.
Not the visual.
What about steroids with the progression of MS? What the optic neuritis treatment trial showed, people who got IV steroids, they had fewer attacks of MS. Fewer of them developed MS over the first 2 years. So it seemed to protect them over the first 2 years. After that, however, they had the same rate of development of MS as everybody else.
So taking this point and only this point in consideration, you wouldn't even start these patients IV steroid?
No, I don't do that because of the 2-year effect. No, I don't do that.
So it seems that...
Do you do that? Do you give people steroids without starting? If you're not going to put them on immunomodulation therapy, just...
People from getting MS by starting immunomodulatory treatment early. You're delaying it. And that's the same thing what steroids do. You're delaying the manifestation. So either of those strategies really has the same rationale. If you start early with immunomodulation, you could just as well argue that, giving the short course of prednisone for a few days as opposed to injecting yourself, every week, achieves the same thing. You're delaying the onset of the next thing, and that's like I say, that's what we're interested in for long-term disability is preventing relapses, so that you have less axonal loss and you have less chance in the 10-15 year period of eventually getting physical or cognitive disability.
There's a paper in neurology in the late 80s by Dorelli, and what he said is that if you treat with steroids, IV and then PO, that the oligoclonal band rate in the spinal fluid drops in patients, depending on the length of treatment from 3 to 6 weeks. And so if you think about that, then maybe there's value, and maybe that's why the patients have delayed recurrences during that first 2 years or so when you treat. So there's maybe some value.
Peter, I think for the sake of time, we'll just move to the next